I would like to invite Dr. Mahesh Bharathi for his talk on intractable neovascular glaucoma.
At the outset, I would like to thank KSOS Scientific Committee and Dr. Smita for giving the opportunity. I would be talking about neovascular glaucoma, which itself is refractory, and the topic is intractable neovascular glaucoma. And we being in the capital of diabetic capital of India, all of us deal with diabetic patients and neovascular glaucoma, whether it's a glaucoma person or a VR person. So the outline would be about a short introduction and a pathophysiology, the principles of management, and evidence-based surgical options that are available, and a summary. So as I said, it's a refractory glaucoma, and the major causes are, whenever we ask a PG student, they tell diabetic retinopathy, CRVO. It's proliferative diabetic retinopathy, ischemic CRVO, and the third important cause is a carotid artery occlusive disorder or ocular ischemic syndrome, and even chronic uveitis. And the pathophysiology, as all of us know, is the hypoxic retina, which generates the vascular endothelial growth factors, and they cause neovascularization of the disc or elsewhere, and which percolates through the pupil and comes into the anterior chamber and causes NVI and also NVA in the angle, which grows on to form fibrovascular membrane, which can physically obstruct the aqueous outflow in the open angle stage or close peripheral anterior synechiae and cause a zipping angle closure and cause closed angle stage of neovascular glaucoma. I'm talking about the four pillars or principles of managing neovascular glaucoma. We have to absolutely take care of the underlying systemic disease and then take care of the treating underlying ischemia, control the inflammation, and then comes controlling intraocular pressure. We'll leave the rest and we'll focus on managing intraocular pressure. So as I told, it's a refractory to medical management, needs aggressive, multimodal and multi-speciality care. And the surgical options that is available to us as of now are augmented trabeculectomy, glaucoma drainage implants, and cyclophotocoagulation. So let's go into each of it. Trabeculectomy has been the gold standard, but especially in neovascular glaucoma, it has a high risk of failure because of extensive fibrovascular proliferation, inflammation, and scarring. So we talk about augmented trabeculectomy, and the options available to us as of now are mitomycin C and 5-fluorouracil. Ologen is not available anymore. And with the advent of anti-VEGF drugs, anti-VEGFs have played a major role in reducing the vascular proliferation in post-neovascular glaucoma and decreasing the fibrosis, and using releasable or adjustable sutures to titrate the bleb. Now, looking at a major retrospective study conducted by my mentor at our alma mater at LV Prasad, where they looked after the surgical success of TRAB and with respect to the causes. The success of TRAB is best among the three in ocular ischemic syndrome compared to ischemic CRVO, and then it's the success is reduced in proliferative diabetic retinopathy. And the risk factors for failure that was noted were older age and a persistent neovascularization of the iris, a need for higher anti-VEGF injections before going for trabeculectomy, or doing a delayed surgery. All this led to an increased failure of trabeculectomy. Now we have a choice of, there has been a debate whether trabeculectomy with MMC or can we use trabeculectomy with anti-VEGF in the subconjunctival space. So a couple of major randomized controlled trials published in the Journal of Glaucoma, they talk about subconjunctival bevacizumab is safe and effective in controlling intraocular pressure. But over 1 year and 2 years follow-up, mitomycin C augmented trabeculectomy has always been superior than subconjunctival bevacizumab. The mode of delivery here discussed is subconjunctival bevacizumab, either as injections or sponges. Now, what if, so we can conclude in the previous one that MMC is superior to subconjunctival VEGF. Now, what if we add bevacizumab, which is an adjuvant anti-VEGF, to a TRAB with MMC? So the bevacizumab in trabeculectomy study tells that adjuvant anti-VEGF is beneficial either in the intracameral space or in the intravitreal space. It reduces the MMC related complications, improves the survival of the bleb and its morphology, especially with respect to thin cystic blebs, and the bleb-related complications are less seen when we give intravitreal, single dose of intravitreal bevacizumab along with a trabeculectomy with MMC. Going on to the next available options, we have the glaucoma drainage implants. We have the Ahmed glaucoma valve, or the non-valved implant, the Barwell glaucoma valve, or the Indian prototype ADI, Orolab aqueous drainage implant, and the latest ADI 250, or the non-valved Ahmed's compatriot, which is the Ahmed Clear Path, and the Paul glaucoma implant. So, as we know, valved glaucoma implants are indicated when we need early post-operative IOP control, and they have a less chance of hypotony, but they come at a cost. Whereas the non-valved implants, they have a delayed but prolonged IOP control. The risk of hypotony is there, but can be prevented with modifications. They are cost effective. No financial disclosures here. This is a recently done ADI 250 with a, where the surgery has been very easy. I didn't have to dissect the muscles because the size is small, which can be kept in between the intramuscular spaces between the superior rectus and the lateral rectus. And the tube has been occluded by a 3-0 proline suture and also the ligated with 8-0 vicryl. So, can we augment the glaucoma drainage implants also with anti-VEGF? Again, two major randomized control trial and a meta-analysis which says that the success rate of Ahmed glaucoma valve, here they have studied only the intravitreal bevacizumab with respect to Ahmed glaucoma valve, which improves the success rate, reduces the complications, and reduces the aqueous humor VEGF levels, which extrapolates to tell that the hypertensive phase of AGV can be reduced by giving an intravitreal bevacizumab and reducing the aqueous humor VEGF quantity. Now that we have AGV and non-valved implant, which tube to go for? Again, a RCT and a retrospective multicenter trial, which says that both AGV and Barwell have a comparative outcomes, whereas the surgical success in this multicentric retrospective study says that Barwell glaucoma implant has a very high success rate, especially at 1 year, 2 year, and 5 years. And the post-op complications rates are similar, but the need for reoperation is excessively more in AGV as compared to a Barwell glaucoma implant. Can trap be still be better than tube? So, what does the trap versus tube comparison say? Similar surgical success is seen both in trap and tubes. IOP reduction, visual acuity, and number of medications at the last visit. But this multicenter trial, which says compared between the outcomes of tube, especially the BGI, Barwell glaucoma implant, and trabeculectomy, especially in neovascular glaucoma, they claim that the Barwell glaucoma implant has a higher success rate, similar post-op complications, but the rate of reoperation has been more in trap as compared to tube. A short note about cyclodestructive procedures usually used as the end-stage disease for pain relief. With the advent of micropulse CPC and the endoscopic cyclophotocoagulation, they are nowadays considered in the early stages, or if patient is unfit for glaucoma filtration surgery. And it's claimed that endoscopic cyclophotocoagulation via anterior route via endoscope target ciliary processes, and to achieve a 30% reduction in intraocular pressure, a 3-quadrant ablation is needed. A quick take clinic message would be, it's a highly complex secondary glaucoma requiring multimodal and multidisciplinary care. Management of underlying pathology and ischemic retina remains the mainstay. Effective control of inflammation is an essential adjuvant in the management of NVG. Though trabeculectomy has high risk of failure, adjuvant trab can survive longer, and adjuvant anti-VEGF with trab MMC increases the survival, improves the morphology, and reduces bleb-related complications. Despite the trab versus tube debate, a well-planned anti-VEGF augmented trabeculectomy is worth considering, especially in eyes with pristine conjunctiva. Non-valved tubes offer a superior long-term IOP control with fewer medications, provided post-op hypotony is carefully mitigated. And cyclodestructive procedures, traditionally reserved for end-stage NVG, is increasingly being used in the earlier disease stage also. Thanks to my mothers in glaucoma and my alma mater both at LVPI and JIPMER, and thanks for a patient hearing. Thank you.